Hello, and welcome to another live broadcast with MedStar Health. My name is Mishan Bowman, and today I'm joined by Dr. Duane Campbell, vascular neurologist and neurohospitalist at MedStar Union Memorial Hospital and MedStar Good Samaritan Hospital. Dr. Campbell is also assistant professor of neurology at MedStar Georgetown University Hospital. In addition, here we have Dr. Douglas Mayson, assistant professor of vascular neurology at MedStar Georgetown University Hospital. Today, we're going to be talking about strokes, what they are, how they're treated, and if they can be prevented. So if you'd like a better understanding of strokes and how to reduce your risk, stick around, share this broadcast with your friends, and share your questions with us in the comment section below. So welcome, Dr. Campbell and Dr. Mayson. Thanks for taking the time out for this broadcast today. Before we begin our discussion, will you please tell us a little bit about yourself and your specialty? So I'll start with you, Dr. Campbell.
Great. Hi, thanks for having me. I was born in Jamaica, but grew up in the States for the most part. And I did a neuro-ICU fellowship and a stroke fellowship as well. I really love great patient care, and I think that the field of neurology is rapidly advancing, and happy to be here.
Great, thank you. You, Dr. Mayson?
Yeah, so I'm Doug Mayson, and I was born in the UK and grew up mostly sort of in Alaska, but we moved around quite a bit. And I also am a vascular neurologist. I did vascular neurology fellowship training after I finished my residency in neurology, and really, very much enjoyed, my career so far, taking care of stroke patients.
Well, great. Welcome again, and thanks for taking the time for this today. So first, I'll start with Dr. Campbell. Could you describe what happens during a stroke?
Yeah. So the brain is very sensitive to any lack of blood flow. The brain needs oxygen and glucose, which is sugar, for it to stay alive. And unfortunately, when you have an ischemic stroke, which is when a clot has blocked a blood vessel, there's a lack of blood flow to the brain and brain cells die. There's also a hemorrhagic stroke, which is essentially a similar issue where a blood vessel breaks open and there's lack of blood flow to the brain and a few other issues.
Thank you. So along those lines, could you also share possible causes of a stroke?
Yeah, there are many different causes for a stroke, but in general, to focus on the more common ones that are a problem for the population at large, high blood pressure is probably the #1 offender. It's about 40% of the risk of strokes all across the nation. And so we really mean it when we say hypertension or high blood pressure is the silent killer. It's a major problem. If we could fix high blood pressure alone, 40% of all strokes would go away. That says a lot. Diabetes is a problem. So running a high sugar is really problematic, increases the risk of stroke. High cholesterol, obesity, those are problems as well. Another issue is smoking. Smoking, essentially, depending on how much you smoke, it doubles the risk of you having a stroke, and ischemic stroke in particular. And, doing things like drugs like cocaine and such obviously can play a role as well.
Thank you. Also, could you share who is typically affected by strokes? Does age come into play, your gender, anything like that?
Yeah. To talk about something a little bit rare first before we talk about the more common, anyone can have a stroke. Pediatric age groups can have strokes, young people can have strokes. And so that's important to recognize, because if you are having the signs and symptoms of a stroke and you're young, you should still take that seriously, despite what I'm about to say next. Mm-hmm. The groups that are most commonly affected by a stroke are people age 40 to 60 as a common group, and then the most common are people age 60 to 80. So the older you are is the greater the risk of you having the more typical strokes. Men and women have some slight nuances with their strokes, because women live a little bit longer than men in general. They have a tendency to have strokes later on in life. And in fact, many of their strokes, if you look at it, are more severe because they have a tendency to sometimes have strokes caused by clots thrown to their brain because they live longer and they have those strokes at a later age. But men are at high risk for stroke as well, and they actually have a slightly higher incidence, especially if you're looking at younger age groups. And then there are some race differences as well. Like, of course, everyone's at risk for stroke, but it's important to note that, you know, African Americans in particular have a pretty high rate of stroke, and they have they can have a slightly worse outcomes from stroke as well. And we think a lot of that is due to high blood pressure.
It's very fascinating. Thank you for breaking all of those risk factors and groups down. So thank you for sharing that information. At this time, I'd like to pause and welcome our viewers again. If you're just joining us, thank you very much. Today, I'm here with Dr. Duane Campbell and Dr. Douglas Mayson discussing stroke prevention, risk factors, and available treatments. So far, we've discussed what strokes are, what causes them, and who's more likely at risk or typically affected. But we have much more to talk about, so keep watching. Share this broadcast with your friends. Give us a like to let us know that you're here and you're watching, and share your questions and comments with us below. We're going to take some time to answer those as well. So I'll go back to Dr. Campbell again. Could you share what are the signs and symptoms of stroke, and why is it important to get to the hospital as soon as possible?
Yeah, this is really critical. There was a study that was done that showed only a third of people really understand all of the signs and symptoms of stroke and the importance of coming into the hospital urgently. And time is really brain. How quickly you can present to the hospital makes all the difference in the world for all types of strokes, hemorrhagic strokes and ischemic strokes. The signs and symptoms of a stroke really vary, but we like to keep things simple and talk about some of the most common things. And there's this acronym BFAST that's really helpful. And so the B for BFAST is standing for balance. The E is standing for eyes, which means loss of vision. The F is standing for face. The A is standing for arms, which is weakness of the arms. The S is standing for speech, which is any changes in your speech, slurred speech or confused speech, where someone's just speaking very differently and calling a tomato a pen or something like that. And the T is standing for time, which is to, again, reinforce that if you see any of these signs or symptoms of stroke, you're really supposed to call 911. Don't try and wait out the symptoms, or don't try and call someone else to get permission to come on in. Just call 911 right away, and they will pick you up and bring you to the nearest stroke center where you can get their perfect care in a timely fashion.
Thank you. So very important to know that timing is key. Thank you very much, Dr. Campbell. At this time, I want to turn over to Dr. Mayson. Could you share what is the first line of treatment when a stroke patient arrives at the emergency department?
Yeah, so thanks for asking that question. So the first line of treatment is a medication called sort of TPA, or thrombolysis would be another term for it, or what I would refer to it as with patients would be a clot busting medication. And as Dr. Campbell talked about a little bit already, we know that strokes are caused by a blockage in a blood vessel, and that can either be due to problems with the blood vessel itself inside the brain. Pretty commonly, cholesterol disease can cause a clot to form and a blood vessel to get blocked off, or potentially you can throw a clot from the heart. And it's certainly oversimplistic, but I like to kind of tell my patients, explain it sort of a little bit in terms of plumbing, right? So your kind of carotid arteries go up to your brain, and they're essentially sort of like pipes, right? And those pipes kind of, as they go up towards the brain, they sort of start out bigger, they branch into smaller and smaller little branches. And so if you sort of potentially have a blood clot that forms in the heart for a condition like atrial fibrillation, that blood clot will sort of flow downstream, and it'll block off one of those pipes. And the brain tissue that's downstream from that doesn't get those nutrients that Dr. Campbell talked about earlier. And that leads to sort of stunning of the brain tissue initially, and very quickly irreversible injury and sort of death of the brain tissue that's supplied by those vessels. So the treatments that we have for acute stroke are all very time sensitive for that reason. So, one of the things that you'll hear us say over and over and over again is, as soon as you have some of these symptoms in the BFAST symptoms involving sort of balance, eyes, facial droop, arm weakness, speech problems. The most important thing is the time part. The most important next step is that it's all time critical, and call 911, get an ambulance to bring you into the closest hospital possible. Because what we need to do is try to get those blood vessels open as quickly as possible. Essentially, we have sort of two options. We have a medication option, which is TPA, or our clot busting medication, and thrombectomy, which I'll discuss in a little more detail later. The thrombolysis basically works by sort of breaking up that clot. It's a medication that we give through an IV, and it breaks up the clot and restores sort of blood flow to the brain tissue downstream. And it's been shown in multiple studies to be an effective medication for improving how patients do over the long term, which basically means it helps reduce a patient's disability. So you can what they looked at was patients who had some disability related to stroke versus patients with no disability. And there were significantly more patients who were treated with this clot busting medication who ended up over the long run having little to no disability, no disability or sort of just symptoms.
Thank you very much, Dr. Mayson. It's good to know that there are medications out there, and they're easily accessible and available, so we can treat patients. So in addition to the medications that you just spoke about, are there any procedures that can stop strokes too?
So there's a procedure that's called thrombectomy, and it's performed by a specialized doctor with additional training, 2 or 3 years of additional training, called a neurointerventionalist. And basically what these doctors do, or neurointerventional radiology is another name for them. And basically what they do in a certain group of patients is basically to remove that sort of blood clot from the brain mechanically. And the way that you'll do that is basically to make a little puncture, a little tiny incision in like an artery in the leg. They take a plastic tube and they sort of snake it all the way up from the femoral artery, or the sort of biggest blood vessel in the leg, all the way up into the blood vessels in the brain. And they can either use like a suction device or almost what's a stent device to sort of grab onto that clot and essentially pull it out. They remove the clot from the blood vessel and restore sort of blood flow to the brain tissue downstream. It's available for people who have a bigger blood vessel that's blocked off in the brain, which we would see on special CAT scans that we do when patients come into our hospitals, that use a dye to look specifically at the blood vessels. And if we see a big blockage, then patients are potentially eligible for the procedure. And it's a very, in those patients who would go on to have the really terrible strokes, the big blood vessels usually lead to big strokes. It's been shown to be very effective, and we know that patients, if you treat sort of somewhere in the range of 3 patients, 2 to 3 patients, for every sort of 2 to 3 patients you treat, 1 additional patient will move from having significant long-term disability into functional independence, which is a really sort of powerful treatment compared to many of our other medical treatments that are available out there.
That's awesome to hear. Thank you for explaining that. So could you also share what is the biplane angiography suite? It's a long term, but could you
the biplane sort of angio suite for short would be it's the room in which these procedures are performed, the sort of thrombectomy procedure. And they're specialized rooms. We have them for dedicated for performance of thrombectomy and other procedures that these sort of neurointerventional doctors perform. We have them at sort of 3 of our hospitals, at MedStar Georgetown, MedStar Franklin Square, and MedStar Washington Hospital Center. And basically the way it works is that it's there are these two arms essentially that allow the doctor that's performing the procedure to shoot X-rays from different angles. And so what the doctor will do is make a little incision in the leg, pass like this sort of plastic tube catheter all the way up to the brain, and then select different blood vessels and do a little injection of contrast, shoot these x-rays, and you can get these like beautiful detailed pictures of the blood vessels in the brain that allow you to perform either these procedures, the thrombectomy procedure, in order to get those blood vessels open again. But it's a specialized room that that's requires sort of specialized folks to be able to run it and to be able to do these procedures.
Thank you very much. So could you also share what symptoms indicate that patients may have a blood clot or be at increased risk for blood clots?
Yeah, so there again, we've kind of mentioned this earlier, but the symptoms of a stroke are they hit you immediately, and it's essentially just very sudden onset of neurological symptoms. And so, if we go back to our BFAST sort of algorithm, the mnemonic, so that may mean for somebody that they suddenly just lose balance and they can't walk, or they suddenly lose vision in like half of their vision in their eyes. For that, you can have a facial droop that comes on all of a sudden, arm weakness, so you may not be able to move an arm, or it may sort of be clumsy or hard to use, and speech problems too. So you, like Dr. Campbell mentioned, you can just use the wrong words for things, or potentially even just slurred speech. And essentially any of these symptoms, if they hit you just all of a sudden, really over sort of seconds to a few minutes, those are symptoms of a stroke. And the first thing if you witness it, or if it happens to you, the first thing you should do is call 911 and try to get to your, they'll bring you to your nearest hospital to be treated.
Great, good to know. So when should patients start being monitored or seek treatment? You did mention, when you first notice those signs, it's good to call 911. Time is of the essence. But when should they start being monitored?
Right when the sort of stroke symptoms occur, patients would come into the hospital and we consider them for treatment. And at that point, we generally bring them into the hospital and monitor them, in the days ahead. Sometimes patients can have, they'll come in, they'll have an obvious stroke, some weakness in the arm or something like that, and we'll treat them. There's some patients who have maybe a blockage of the brain that opens up either with treatment or without treatment, and their symptoms can come and go. And that's also a pretty high risk situation. And so we'll bring those patients in and monitor them in the hospital and try to figure out why that happened. Generally means doing some testing. We'll do a picture, an ultrasound of the heart called an echocardiogram, some imaging of the blood vessels in the neck and in the brain, as well as an MRI of the brain to look at the brain tissue to see if we can figure out why, and see if we can figure out are there some treatments, can we put the patient on an aspirin or some other kind of cholesterol medications to try to help them, or does their blood pressure needs to be addressed a little bit more aggressively?
Great, thanks. So I'll go back to you, Dr. Campbell, at this time. Could you share what is a TIA and how is it different from a stroke?
Yeah, that's a really good question. So a TIA and an ischemic stroke they're along a spectrum, if you will. The old definition of a TIA was essentially someone having stroke-like symptoms that goes away after 24 hours. And now with these modern MRIs and such, things have changed a little bit. In practice, what a TIA is something that lasts about 5 to 15 minutes, where someone gets sudden stroke-like symptoms. It could be the balance, it could be loss of vision, it could be the speech change, it could be the facial droop, the arm weakness, what have you. But those symptoms come on suddenly and then they go away after 5 to 15 minutes. And what's happening physiologically is that a blood vessel, an artery, is getting blocked, whether it's an artery or capillary, is getting blocked for a brief amount of time for those 5 to 15 minutes. And then the clot breaks up on its own by good luck, happenstance, whatever it is, and the blockage is gone and the symptoms go away. So imagine if you have a water hose and you block it suddenly, the water stops going through and you get symptoms for 5 to 15 minutes. the blockage in the water hose goes away, and the flow continues and the symptoms goes away after the 5 to 15 minutes. So that's a TIA. The 5 to 15 minutes, or that brief amount of time, is important because brain cells will die if you block any blood flow for a prolonged period of time. And so if you block brain cells for hours, usually that leads to stroke symptoms that will not go away. They will persist in some way, shape, or form. And more importantly, with modern stroke centers, we have these devices called MRIs, where if you've had symptoms that have gone on for long enough or severe enough, we will actually see that the patient has had a stroke, and we'll tell you, even if you felt much better after the symptoms have kind of dissipated a bit, or they lasted, say, 8 hours, we'll tell you, we saw signs of a stroke on the MRI. A TIA, because it's transient and no brain cells die, doesn't leave marks on the brain. So it's different than a stroke. And a stroke will leave marks on the brain because brain cells died, and that's how you know it's a stroke. But it's related to the severity and how long the symptoms went on for. Again, typically 5 to 15 minutes for a TIA versus a stroke.
Okay, thank you for explaining that. So earlier we shared some risk factors for stroke. So could you share what are some of the risk factors that could increase? What are factors that could increase one's risk for TIA?
Yeah. So essentially, the risk factors for a stroke and a TIA, for an ischemic stroke and a TIA, are essentially the same. It's high blood pressure, again, being probably the number one culprit. Diabetes, where your sugars are running high, your cholesterol, smoking, drugs, all those different things. There's one thing that's been kind of somewhat touched on a little bit, where you can have TIAs also related to large blood vessels that have cholesterol buildup or plaque or thrombus, which is little clots on it, and they can flick off pieces of debris. So as blood is going up your carotid arteries, which supplies 2/3 of the blood flow to that side of the brain, the little pieces of debris can fly off of it, go up further in your brain, and give you a transient ischemic attack. And in the same way that they can give you a stroke as well. And that's another reason why people can have these symptoms. But effectively, TIAs and strokes have the same fundamental causes.
So for people who have those risk factors but haven't had a stroke, or at least not yet, could you talk about how you can manage those risk factors, some preventative things that people can do?
Yeah. That's really super important. The reality is that the majority of strokes can be prevented. And one of the things that stroke centers do is we try to treat the upfront stroke to make the symptoms go away. And we also try to make sure that the stroke that you just had is the last stroke that you'll ever have going forward. And the same thing also with the TIA, that if you had a TIA, the TIA that brought you into the hospital is the last ischemic event of any sort, TIA or stroke, that you ever have, by changing your medicines and such. And so changing the medicines is a big part of it. In some cases, sometimes you need changing of the medicines and fixing of an artery or a procedure, et cetera. But for now, I'm going to focus on lifestyle and medicines, because these two things are both very important. If your diabetes is poorly controlled, we find that diet change, education about the importance of what you're eating and such, and the medications, both of those together are really important. High blood pressure is a scourge in this country. Again, 40% of all the vascular events are related to high blood pressure, and it's preventable. And so we try to find the right blood pressure regimen for that patient so that their blood pressure is treated. And that's something that quite often will need some follow-up. All these things usually will need some follow-up with their primary care doctor. But we start them on the best medicines possible in the hospital, and then we send them out. The cholesterol is a bit of an issue, and most patients will end up needing something called a statin or some similar medicine. And these are medicines that lower your bad cholesterol, the LDL. And the LDL is the number that we usually follow the most. But again, with everything, medicines are not the entire part of the solution. there's lifestyle parts to it too. So we encourage exercise, we encourage diet changes, because especially the exercise and such, they can raise your good cholesterol, the HDL and such, in ways that are very important. And then in terms of the risk of a stroke and preventing them going forward, a lot of times you end up needing a medicine that's going to thin your blood a little bit. And those medicines can be what we call antiplatelets, which is aspirin and Plavix are the most common ones that we use, or they can be actual full blood thinners. For example, if you have something called atrial fibrillation, we'll quite often put you on an anticoagulant, for which the older school medicines are Coumadin and the newer ones are called NOACs.
Thank you for sharing that information. At this time, could you share what types of procedures can be done for people with carotid artery disease to prevent a stroke?
Yeah, that's a really good question. So carotid artery disease usually leads to large strokes that you can get a warning sign sometimes with a TIA if you're fortunate. And for those who are unfortunate, they can sometimes have what we call a large artery to artery embolic stroke. And so it's very important that we address those. And the two major ways that we address those is through medicines or procedures. We've talked a little bit about the medicines a bit before. To talk about the procedures, essentially there's two things. There's either stenting or there's carotid endarterectomy. And the carotid endarterectomy it's been around the longest, and it's a little bit of the gold standard, but in some cases it's not appropriate, and then we do the stenting. A carotid endarterectomy is essentially when a surgeon is going to actually make an incision along the carotid artery, which is here, and they're going to open up, they clamp the carotid artery first so that there's no bleeding. They open up the artery and then they literally clean it out and make it like brand new, suture everything up, unclamp the artery, flow is restored, and inside that artery, it's almost like brand new. So it's beautiful. A carotid stent is a little bit different. It's similar to what Dr. Mayson was discussing before. It's an intravascular procedure. There's a stick that's made in the groin, sometimes in the arm, but either way, they access an artery intravascularly through the artery itself. And they actually will deploy a stent in the carotid artery right there to keep it open. When you get a carotid stent, there are certain medicines that are important for a time frame to keep the blood flow going through the stent. In general, if you can have an endarterectomy, that's usually a little bit preferred. But then again, there are some patients where they have special considerations, and the stent is what's preferred in that case.
Great, thank you. I know you touched on this a little earlier, but could you also share the best way to prevent a stroke? You mentioned earlier that this is preventable. Yeah. There's some diet and lifestyle changes and that you would have to make. But could you share, just reiterate that message that this can be prevented?
Yeah, I agree. Stroke is a huge part of the public health effort. The reality is that what every stroke neurologist would love is that essentially they had no customers, that there was no one coming to the hospital that needed to see them. To help prevent strokes, from what I've seen in our communities, high blood pressure, very, very important. Really want to make sure that you are doing everything that you can to keep your blood pressure well controlled, keeping your sugars well controlled, not smoking. The more you smoke, the worse off it is. If you really absolutely can't quit, at least try and reduce how much you smoke. These healthy lifestyle choices really make a huge difference. To some degree, as we get older, there will always be some increasing risk of stroke. But if you have a healthier, happier lifestyle, take your medicines as directed, following up with your primary care doctor, doing all those different things, your chance of stroke will be much less. And I think that's the important message.
Absolutely. Dr. Mayson, could you share at this time what the stroke program at MedStar Health is all about and what we're doing to treat patients?
Sure. I mean, it's a pretty big program that's been, has been an important program in MedStar for quite a long time now. So it certainly can't go into everything, but to give a little bof a sense about it, we have 9 acute care hospitals within the MedStar system, and all of those hospitals see a good amount of stroke and have well-tuned systems in order to take care of stroke patients as quickly as possible. We think of it as sort of the one of our jobs as sort of educators is to try to educate the public to try to get them to come in or to get their family members into the hospital as quickly as possible. Our part of that in the hospital is to try to do things as efficiently and safely as possible in order to get patients treated quickly, because we know that like every passing minute there's more brain tissue dying, and so there's a lot of emphasis that's been placed on trying to cut that time down in a safe way. Usually that means doing multiple things at once, CAT scans, and getting sort of IV access at a sort of similar time, and sort of assessing the patient sort of all in a sort of compressed, but like efficient fashion. We obviously want to be really careful with how we treat our patients. At MedStar, all of our hospitals are capable of treating stroke patients. They all have, we all put emphasis, at the different sites on getting these patients treated quickly and efficiently. And in addition to kind of deciding whether a patient's a candidate for TPA or not in an efficient fashion, our system of hospitals has the sort of the resources and the neurologists and the staffing in order to take care of those patients when they're in the hospital, because you'll come in as quickly as possible. We'll try to treat you with a clot busting medication or another treatment, if possible. But the next step after that are some of the things that Dr. Campbell alluded to, and that's figuring out why the stroke happened and what we can do in terms of changing medications. There are 3 hospitals within the system: MedStar Georgetown University Hospital, MedStar Franklin Square, and MedStar Washington Hospital Center that also provide thrombectomy care. So if the patient is found at either at those hospitals or at some of our other affiliated hospitals to have a big blocked blood vessel in the brain, the patients would be transported over to one of these hospitals, generally by air ambulance, by helicopter, and in order to try to get the patients treated as efficiently as we can. And those MedStar Georgetown and MedStar Washington Hospital Center are what we call comprehensive stroke centers. Okay. The rest of the hospitals are primary stroke centers, and MedStar Franklin Square is on its way to becoming a comprehensive stroke center, although it already provides all the care that our comprehensive stroke centers provide, which includes neurosurgery expertise for patients. Sometimes we haven't talked much about it, but you can also have a bleeding type of stroke. And so that usually a lot of times will require neurosurgery expertise. And then the neurointerventional piece as well, where patients can have a thrombectomy performed in the biplane angio suite and receive care in our neuro critical care units after those treatments are done, because generally these are our sickest patients who were brought over to our thrombectomy capable centers. That's sort of a broad overview. Did you have any specific areas that you think I should clarify?
No, I think you covered it all. I think it's good to know, it's reassuring to know that all of our MedStar hospitals are equipped to at least treat stroke patients. And it's good to know that we have those comprehensive centers, just in case, we need to, do a deeper dive into what the cause of that stroke is and how to treat it as well and prevent it from happening. So thank you for sharing that.
Sure. I think I had one additional sort of plug, I guess, that I forgot to, that I neglected to mention, was also that we at MedStar, we have a regional telestroke system as well. So specialty trained vascular neurologists like myself and Dr. Campbell, and there's a number of other ones within the system we all take turns covering 24/7 the entire system for patients who are coming in with acute stroke, so we can make sure that every patient in every hospital gets the best specialized stroke care possible. And if they do need additional therapies, we're able to figure out that as quickly as possible as well. So I just thought I'd mention that part of care that we're able to provide at MedStar.
Absolutely. Thank you for sharing. So at this time, we have a few questions from our listeners on social media, so we're going to take some time to answer those. So our first one comes from Karen. She asks, can you have a stroke and not realize it? And what happens if you don't do anything about it? Is that how lesions are caused on the brain? So I'll direct that to Dr. Campbell.
Sure. Yeah, there are people who are having a stroke and they don't realize it for a variety of reasons. Sometimes your brain is what allows you to be aware of what's going on to you. And strokes on the right side of the brain in particular can sometimes be having overt symptoms to other people that can look at you, but you are not aware that you are actually having a stroke because your awareness has been impaired by the stroke itself. So if you were by yourself, you wouldn't be aware of the fact that you're having a stroke, but someone looking at you would be aware that you're having a stroke. And there are also some strokes that are, even if someone was looking at you, it would be a challenge for them to be aware that you were actually having a stroke, because usually the stroke is so small, or it could be in an area of the brain that has nothing to do with motor control or sensory control and is more of a cognitive area and such. Those types of strokes are very rare. And so we really always try to focus on the BFAST stuff, because we want to prevent the strokes that are clinically obvious and devastating and such that where timely showing up is extremely important. But yes, it can happen. The second part of the question was essentially, what's the significance if you're not aware of it and not coming in late? Of course, with everything, with any type of stroke, the faster that you can come on in, the better the outcomes from treatments that we would offer you, and the greater the likelihood that you wouldn't be aware of any problems. So that really applies for those right-sided brain strokes where you may not be aware, but someone looking at you would be aware. The totally clinically silent strokes, that's really a thing where it's more of an academic question. If you were not aware that you were having a stroke and me looking at you, I wouldn't be aware that you're having a stroke. The likelihood that there would be a treatment offered is low. And usually what ends up happening is that those spots are found on an MRI or a CT scan sometime later down in the future. And someone says, hey, did you know that we found a mark on your brain that seems to indicate that you had a stroke that was clinically silent? And sometimes essentially what's the outcome of that is that there's a conversation that you have stroke risk factors and we want to adjust your medication so that you never have another stroke again. And that's usually how that plays out.
All right, thank you. And thanks, Karen, for sharing that question. We have another one from Angela. It says, if you have been treated acutely for a stroke, but are still having residual weakness after a couple of weeks, is there any chance one-sided weakness will improve over time? So I'll direct that to Dr. Mayson.
There is, and I think if you the rule I think of when it comes to stroke is that the improvements, unfortunately pretty slow and gradual in most patients. But at the same time, the brain has some built-in sort of neuroplasticity or built-in ability to try to rewire itself and try to adapt to part of the brain tissue that is essentially kind of taken offline, that it's been permanently damaged. But that process takes months. And patients with motor weakness can continue to improve out to sort of 3-6 months, sometimes even as far out to a year. And with difficulty with language, patients will even continue to improve oftentimes after a year. So, after, this spend most of our talk on the sort of acute side of stroke, but over the longer term, when as patients are living with and trying to recover from their strokes, it's really important to continue to see your doctors, and there are special rehab doctors that you can see, and also to follow with your physical therapist, your occupational therapist, and your speech therapist, because very often they'll help kind of guide the ongoing sort of continued rehab you'll need to help you get back, as much of that strength as you possibly can.
That's all good to know. Thank you for sharing that response. And thank you, Angela, for asking us your question. As we close, I have a question that I'd like to share with both of you. So what do you most want people to take away from our conversation today about stroke? And I'll start with Dr. Campbell.
Sure. I think that the two things I'd say is that obviously MedStar has really invested tremendously in taking care of our community. This is the community that we live in. These are our neighbors. These are the people we love. And we really love taking care of our patients and advancing the science behind taking care of our patients. I also wanted to say that a lot of your health is in your hands. We are obviously here for when an emergency happens, but really and truly, the lifestyle modifications and staying up to date with your medications and taking them faithfully, those are extremely important. So much of the outcome of our lives is in our hands. And if we make good decisions, the chances are much lower of having something like a stroke.
Thank you. Dr. Mayson.
Yeah, I was actually going to say much of the same things. I guess I would add on just that, as we kind of talked about, time is just such a critical part of our treatments. And for the two main treatments that we have that can actually change how the course of things and improve how patients can do really significantly over the long run, maybe even, eliminating disability in some patients, improving many patients. It really comes down to time. And I just would encourage patients that if they see symptoms in a loved one or even in themselves, that there's kind of no symptom, there's no neurological problem that's like, I don't think that if something comes on all of a sudden, there's no symptom that hits you all of a sudden, that's kind of too silly to not just get checked out in the emergency room right away. And I'd recommend patients, who do have some symptoms that, fall into the sort of this be fast mnemonic, that, call 911, get the ambulance to bring you in, and we'll be happy to take care of you. And hopefully it's a false alarm, but you can never get that time back.
Well,
So
thanks to you both.
Call as soon as possible.
Absolutely. Thanks to you both. That wraps up our broadcast. This was a very important discussion. I've personally speaking, I've had relatives who have been affected by stroke. Not all of them have had the best outcome. So this was very educational for me, and knowing what to do to prevent them is key. So thank you very much for taking the time, Dr. Campbell and Dr. Mayson, for speaking with us today and sharing this important information. Thanks to all of our viewers for tuning in and sharing your questions and comments with us. If you'd like to learn more about stroke prevention, risk factors, and treatment, please dial 202-444-8532. That is the number to the MedStar Georgetown Stroke Clinic. If you're in the Baltimore region, you can also reach out to the Neurology Clinic at MedStar Union Memorial Hospital and MedStar Good Samaritan Hospital by calling 410-554-2286. We're going to share those phone numbers in the comment section as well. So thanks again, Dr. Campbell, Dr. Mayson, for joining us. We'll see you next time. Bye.
Thank you.
Thanks, Michelle.